So Alex Miller is the president and founder of Esri Canada, the leading GIS company in Canada, founded in 1984. He's a pioneer in transforming geography and mapping into a 21st century digital tool used by millions around the world. Alex's work has helped people see location as a unifying lens through which complex problems are understood. Esri Canada has been doing some very interesting work around making COVID-19 data readily available. Are you ready to go live, Alex?
I am.
All right.
Finally.
Yes, it's yours.
Okay, let me, now I got to hop in as hiding. Okay, now let's just go back to my PowerPoint.
Yeah, and just share your screen. I mean, sorry, your PowerPoint, put it in presentation mode, yeah.
Okay, can everyone see this?
Yes, perfect.
Can you hear me?
Thank you.
Profuse apologies. It was a security setting on my Mac. Again, I can't apologize enough. Okay, so I think we'll save a little time. I'm going to skip one of the videos that I was going to show, but let me, first of all, thank you very much for having me on. And I'm going to talk about GIS and COVID-19 from our experience and what we think are the things going forward. And so maybe let me begin with a quote from Joe Clark, who is Canada's youngest prime minister, not for long, but his famous quote was, "Canada is a community of communities." And he said in this quote, if you dig into it, in an immense country, you live on a local scale. And governments make the nation's work by recognizing that we are fundamentally a community of communities. So the healthcare community is a very large and complex community, and it is not yet a community of communities, in my view. It's a small number of communities that are serving things local, and health is. So over the last 4 months or almost 5 months, we've been working at collecting data from across these communities, the provinces, the healthcare units, and coming up with daily case counts. And many others are doing the same thing. CBC has got their own initiative, and others, the Globe and Mail, but many others are sharing ours, and I'll come to that in a minute. We're also showing graphs. Everyone else is showing graphs and trying to figure out how do you flatten the curve, where are these cases happening, what are the demographics of the cases. And we can see here that, you don't know if you can read this, but of the 108,155 cases yesterday, 59,000 are not reporting age. And it just goes on and on and on. There's so much inconsistency across the country. And we've got a few dashboards that have a few little analytics in them that are being predictive as much as we can, or at least diagnostic. You see, as of today, the cases counts over a 6-day rolling average are starting to increase again. So when this began, we started looking at other data, not just the reporting data about COVID, but about the health of the population in general. So if we look at this screen here, Paul Begley, who's going to present our demo at noon, is going to show a little bit of this dashboard. But this was taken from a study done in Lancet. The idea was taken from a study done that was published in Lancet in Italy, a chart survey of the first 355 patients. And they identified that these comorbidities, hypertension, heart disease, arthritis, diabetes, were the top ones. And the map is showing, covers all of Canada, is showing where the populations are over 70 in the brown color, and they're showing a density in the blue color. And where you get the dark color, it's both high population density and high blue, and you can go back and forth on this. The data that we put together was shared with the Public Health Agency of Canada, and they're now using our dashboards and some of our data to update their dashboard, and we're using some of their data to keep our dashboard up to date. And many others have built dashboards. I'll talk about this at the end. But this is one where Alberta was looking at how do you service truckers. And of course, when all the restaurants were closed and everything was shut down, truckers still had to go on. So this lets them see where they can find a truck stop. So we're using GIS to create and manage all this data. And I'm going to spend just a couple of minutes here giving a few slides to give you an idea of what is a geographic information system. Many think of it as a system for mapping, but it's more than that. It's about sharing knowledge with each other and sharing understanding and collaborating. So this slide is showing all the different things that can be done with a GIS, including right from collecting data and entering facility data all the way through to engaging citizens. GIS fundamentally supports three systems. That one is the system of record for recording transactions, and I'll talk a little bit about the end how what are kinds of transactions like that we might think of an analogy to healthcare. A system of analytics to let us get insights from those records, and then a system of engagement to engage others in a community, in this community of communities that Joe Clark talked about, and how you bring these systems and workflows together and engage everyone. So GIS is also a framework for managing process, observing the world, understanding those observations, and then responding through measuring, visualizing, analyzing, planning, and taking decisions. So if you look at how does this fit in with healthcare? Well, it's the facilities themselves need to be measured. And I'll come to that a little later. That's a big problem across the country. Cases, inconsistent reporting. Demographics, we've already looked at that. Where are the vulnerable populations? I'll talk about that a little bit later. How do you communicate this? How do you forecast? There's not a lot of forecasting going on. We're seeing massive numbers of descriptive analytics, which is what happened, and maybe even a little bit of diagnostic, but we're just at the beginning of trying to understand how this works. How do we plan? Where do we need masks? Where do testing sites go? And now where do vaccination sites go? And so on and so on. This is because GIS is set up to build an information system about our geography, which contains enormous variety of data. Could be tabular data about cases or the population or mobility data in phones. It could be hospital resources and so on and so on. It just keeps going. And eventually models. How disease spread. We've built up something called the CHIME model from the University of Pennsylvania for BC and started looking at some of that. But as I'll come to later, the granularity of the data that's released by most provinces isn't enough to do much with it in the way of forecasting. So we have been working across the country with lots of healthcare organizations and others, economic organizations, and they're starting to share. They're starting to share models. They're starting to share apps and methods. But we need everyone to start participating in this. You know, Joe Clark's community of communities wouldn't work if the communities didn't agree to cooperate with each other. One area where we've been very successful over the last 10 years in creating a community is to build out a base map, a community base map of Canada from authoritative sources, primarily municipalities. And this graphic on here is showing sort of last fall, there have been 3,000 updates. There's almost 6,000 now, but where they come from and how often are they being updated. These are the, you see tens of thousands of updates coming in from across the country, and it's up to hundreds of thousands now. It uses an exchange to do this that we built out with the federal government that allows this exchange to take open data from various organizations, other sets of data, and publish it first so we can make a community map. But a big one now is the next generation of 911. So we can learn a lot from the next generation of 911 implementations. And in the interest of time, I'm not going to play this video, but we'll make it available to the participants to see. It's about a 5-minute video on how New Brunswick is being the pilot for creating the data needed for a next generation of 911. This is a major healthcare system, if you will, public safety system in New Brunswick. The ambulance group runs it, but they're making a huge change because mobile phones no longer have the address of the phone is not where the phone is, it's where the owner lives. So the next generation is using IP addresses and will result in a nationwide system by 2024 of complete maps of the whole country and sharing across organizations. This was a local function, local to a city or local to a province, but now with IP phones and with mobile phones, they're getting calls from all over the place. They get a call in Calgary saying, my brother in Woodstock, New Brunswick has had a heart attack, can you send an ambulance? The answer today is no. We're not connected to your 911. So then in future, this will all be connected. So another one is building a community property map of Canada. This is a project that's been going on for a little while, but the automation of the property records, land registry, property assessment, zoning has been going on for over 40 years in Canada. And the result is, as we can see here, the whole country is consistently like this. This is looking at a particular property. I chose this because my in-laws live one door south of this. And you can see there's a lot of information here that's been shared. The assessment of the property, the selling price the last time, and this is open data. And if we go look at the title of the property that my in-laws lived in, I can click on that number in there and it launches the land registration. And it shows today that the owner of that property is no longer my in-laws, it's Adam Anthony Snow and Chantel Dawn Snow. So why are these public? Why is this public information? Because it's in the interest of the public to have the transactions and ownership of land shared with everyone, to be completely transparent. And it's been this way for hundreds of years. It was in paper, now it's automated. And if I go in and click on one of these down near the bottom, the transfer of deed, I see the document with my in-laws, William Willard McCormick and Violet Marie McCormick, and there's their signature in the document, and I can do that anywhere. I can also take a look at the assessed value here, and what you're seeing on the screen here is sales, property sales. But we use these sales and models and data about all the individual properties to synthesize market value for every property, bringing it consistently. So this is what Khalib was talking about. So this is again using observations, which are public, and use them to model consistency across the country. It's exactly the same in BC. I can click on a property in BC and get exactly the same thing. Or this is even more interesting. I took this last fall on a flight to Calgary, and I was looking at the window. I looked down that lake, and I had my GPS on my iPad on, and to my amazement, it actually centered my community map on exactly where I was. So I clicked on the map, and I found that that individual property was valued at $242,000. It's the one I'm looking at from the window of the airplane. So other industries, other communities have built tremendous transparency in the data and being able to give it out for access to anyone who wants to use it. So what's next? What are we going to do next? Well, this is from a gallery on our COVID-19 resource site, and it's showing all of the dashboards and access to data that's being built by dozens of communities across the country, actually hundreds and tens of thousands worldwide. But in Canada, and as you can see, they're all different. They're inventing their own. Now they're publishing many of these using open technology, our REST services, but there's no agreement that's really been reached on how do you standardize this. And the Public Health Agency of Canada has taken a shot at trying to figure out how to do this, but it's still a work in progress. One area where I think there obviously were massive problems, 85% of the deaths in Canada came from long-term care homes. And this is a map of the 3,500 long-term care homes across Canada. We'll click on one of them, opening it up. And it looks nice and consistent here, but the reality is, as we zoom in, and there's a lot, there's 325 in Toronto alone in that cluster. And so if I go take a look at this though, this is the reality. They're all different from each other by province. They maintain different attributes. They may not all of them collect the bed numbers, number of beds, not all collect other data. And if we go in and look at a particular one here in Fredericton, we can see a nursing home in Fredericton, but the attributes are different than the national one. Or we can go into PEI and we see something yet different again. So we've been working now for the last several months with an organization. It's the Institute for Investigative Journalism and the Canadian Association of Journalists have gone together on something called Project Pandemic to try to deal with this lack of data and figure out, and they're using reporters. So what we see on the screen here is all these individual dots are a reporter investigating something and looking at issues. So here the comment was on July 12th, case not being counted towards the regional total. So we're hoping that this community of health units, provinces, the federal government, companies, organizations like Canon, journalists are going to come together and try to give us a much better picture of how this pandemic is looking. One organization is called How's My Flattening, which this is one of their maps on their dashboard. And this is an interesting graphic because it's showing the days since the last case. So the bright red is yesterday, the green is more than 30 days. And then the colors are the population per 100,000. So if we go and zoom in on this, Ontario released their data about a month ago to the postal code forward sortation area. And so we look at this little spot in Toronto, which is green, we can see it's been 48 days since there was a case in that postal code. And it's 121 cases per 100,000. But if we go up to North Etobicoke, we can see it's only been yesterday since there was a case up there. And it's 1,294 cases, almost 10 times the number of cases. If you look at the population, it says 60,000 in that postal code, and down here it says 11,000. So there's challenges in using a boundary that wasn't designed for release of healthcare data. This is Canada Post's operational boundaries. So the census dissemination areas are much better, but they're not, the data is not being released at a granular enough level that it can be aggregated up to the census dissemination area levels. We're starting to look at what are the factors. I began with the dashboard on the population density and age over 70 as the spatial and attribute conditions, and then looking at what people's comorbidities were. A big one turns out to be crowding. So if you look at that map downtown there that I just showed you, you can see in the center of the city, here's one probable reason. Down here in the center of the city, only 14 cumulative cases since it began, 48 days since a case. Up here, 781 cases, and they continue to have cases. And then you go look at here, and you can see that the household size in the downtown is dominated by single person households. So even though it's dense, it's not that crowded. Whereas you go look up in North Etobicoke, they're up in the 3-person households, and you go out further on, you get into the 4, you get into the 5-person households. So we haven't done the analysis of this on this correlation because these are different geographies that need to be rationalized. So that's a fast run through, and again, my apologies for messing this up, but I got us back on time here. So,
excellent. Thank you very much, Alex. I think you've emphasized quite clearly the importance of integrating multiple data sources in order to really understand what's going on and to model some of the determinants of the cases and fatalities that we're seeing. But one thing that we discussed in our conversations prior to this is your vision for a health data network. Maybe you can touch upon that a little bit.
Sure.
What would you like to see from where you stand in terms of data access and data integration?
Well, I believe that where systems integration is exceptionally difficult and expensive. If you look across the country, people are very covetous of their systems. They control access, and with health information, correctly so, because if information is really private and you let it out in the wild, there's absolutely no compensation that can be paid to the person who's lost their privacy because it's gone. Unlike banking, where if somebody steals your money, you can make them whole again. So the systems have to remain highly secure. On the other hand, each of them can publish data out to either a completely open data site, where they can publish it to a secure network where people agree to keep it private. But that has to be something, I believe, that overlays on top of these systems as a network, not as a system. So we see this in other areas. That community map of Canada is a network of many organizations working together. And so if I was to go back to the diagram here and share that slide briefly, I'm just going to go to, where did I put it? Oh, here we are. So this is a little, I'll just leave it in presenter in this mode here so I can come back on. So this is kind of what it is. It's a network of organizations who need either go through, this exchange, by the way, in this area is bringing data together and storing it, but it doesn't have to be. It could be just a network of organizations. So this works really well in base maps. It also works really well for that national property map, because individual provinces through their land registries, individual assessment organizations maintain that data and simply publish open services to the data, and that's how we picked it up. So I see a public health information network as standards for data, standards for workflow, standards for access and security, for aggregation, and everyone needs to participate, but it doesn't need the existing systems to be disrupted. It just needs them to be able to open up and export that to some. I'm getting a little prescriptive here right now, but the idea is that you have a network that will result in all the kinds of things that we need to do: analyzing data, responding to an outbreak, recovery. How do we make sure it doesn't happen again?
Okay, excellent. Thank you very much. We're out of time, so I really appreciate you making the time to join us today, Alex, and thank you everyone who joined us for the session. My pleasure, and my apologies for the technical problems. No problem. It worked out at the end. Yeah.